What is your diagnosis? See, this is the again the repeated question of the croak 1. I hope every one of you studied about that. There is one thing we have discussed, sit lid. If you want to solve this question, just remember this sit lid. Sit lid means small intestine will be affected in the typhoid fever. The small intestine would be affected in the typhoid fever and the large intestine would be affected in the dysentery. So now you can see here that the sigmoid gut is standard hardened. It means that this is the example of which condition? That is the example of the dysentery. And the dysentery is caused by the shigella dysentery. Okay, so this is the main thing that you have to remember. Means question will be solved. If in the question they have mentioned that the patient has something diarrhea and the fever would be there, then or there will be the small intestine, mainly the Peyer's patches would be affected. So then it will be the typhoid fever. Okay, so we will discuss about firstly about the salmonella because the questions will come from the salmonella, and then we will discuss about the shigella. Okay, what is the tenesmus? Tenesmus means like incomplete defecation. Incomplete defecation. Okay, like patient will be having difficulty to empty the bowel or difficult to empty the stool. So that is the incomplete defecation or the tenesmus would be there. So write down the headings. Write down the headings. Salmonella. See, when we talk about the salmonella, remember, we have the MO. The MO means these are the motile bacteria. MO means you can remember, MO means that is the motile bacteria. Motile bacteria, whenever I say the motile bacteria, I have mean to say that they have the flagella. I mean to say that what they have the flagella would be present. Because the flagella are only things that help in the movement of the bacteria or the movement of anything. So that will be the motile bacteria. After that, if we talk about that, it will be having some kind of the antigens would be there. The antigens. So remember, they have the three type of antigens. We have the H antigens. The H antigens that is present in the flagella. The H antigen that is present in the flagella. Then they would be having the O antigens. They would be having the O antigens. And this O antigen, it is the somatic. Somatic means that is present all over in the body of the salmonella. Okay, and these are the polysaccharides. These H antigens, they are made up of the proteins. They are made up of the protein, while the O antigen, they are made up of the polysaccharides. They are made up of the polysaccharide. And they also having the VI antigens. They would be having the VI antigens. And these are the present in the capsules. They are the capsular. So we can say that salmonella having the capsular polysaccharides. They would be having the capsules made up of what? Polysaccharides. Most of the bacteria, they having the capsules. If the capsules would be present, they will be polysaccharides would be there. There is some exception would be there. Like for example, the Bacillus anthrax would be there. So Bacillus anthracis, they will be having the capsule that is made up of the polypeptide. Okay, proteins. But other capsules, they are made up of the most of the bacteria. They have the capsule that is made up of the polysaccharides. And the VI antigens, this is the antigen that is present in the capsules. And again, this is the polysaccharide capsules. These are the polysaccharide. Polysaccharide basically means that is carbohydrate. Okay. This H antigen, remember, this is highly antigenic property. They will be having the highly antigenic property. So H4 what? H4 H antigen, H4 highly antigenic property would be there. And remember that this is the very important other keywords, that whenever you will grow the salmonella in the culture medium, there's a lots of culture medium would be there. So remember that they will produce the black colonies. They will produce what? Black colonies. Black colonies on all the medium. Black colonies in all the medium. Okay, so this is you have to remember. They produce the black colonies in all the medium. What the salmonella cause? Salmonella cause the enteric fever. What they will cause? They will causes what? Enteric fever. And remember that the enteric fever, it is caused by the typhoidal salmonella. When I say the typhoidal, it means in the species there will be the typhoid would be there. For example, the salmonella typhi can also cause. Then the salmonella paratyphi can also cause. There is some, I think, 2 years back they give the options salmonella paratyphi, and that was the answer. So remember that there will be the enteric fever. It can be caused by the salmonella typhi, and the salmonella typhi, it is the most common bacteria that cause the enteric fever, and there can be the salmonella paratyphi. Paratyphi, again we have the A, B, C. Okay, they are the species, and they are the strict human pathogens. Means they will affect the humans only. How this salmonella will transmit it? They transmit it through TM means transmitted. They are transmitted through contaminated food and water. Contaminated food and water. Or we can say that which route, if I say, then we call this as the feco-oral route. We call the feco-oral route would be there. Because what feco-oral route, I have to say that the contaminated food and the water itself. So whenever with the human fecus, when the human fecus would be there, the patient would be having the salmonella typhi infections that will contaminate the food and the water, and that will comes in contact with another person. So this salmonella typhi would be transmitted from one person to the another person. This is the first thing. Secondly, they can also cause the food poisoning. But this is not caused by the typhi. They are caused by the non-typhoidal salmonella. Like for example, non-typhoidal salmonella. Okay, now forget this. Non-typhoidal salmonella, like for example, we would be having salmonella donnei or something would be there. So they will be caused by the food poisoning. The main concern is here that you have to remember the salmonella can also cause the food poisoning. The one point you have to remember, the salmonella can also cause the food poisoning. You can forget it. Okay, just put it in your mind that salmonella can cause the food poisoning, and forget this. Then we would be having the enteric fever. Then we will discuss about the enteric fever. There is an enteric fever would be there. So the patient would be having some kind of the abdominal pain would be there. What is the clinical feature? The patient would be having the abdominal pain would be there. The patient would be having the fever would be there. Fever with rigor. What is the fever with the rigor? Rigor means chills. Rigor means chills would be there. The fever with the rigors would be there. And there's sometimes the abdominal pain, fever with the rigors, and the headache can also be there. So all these features can be seen in this patient. Other than that, you have to now see there will be the how you will make the diagnosis of this patient. How they will make the diagnosis. And in the clinical features, you can also write they affect what? They affect what? Small intestine. They affect what? Small intestine. And in the small intestine specifically, they will affect the Peyer's patches. They will affect what? They will affect the Peyer's patches. Okay. So, and also remember, they will be having the, if you think about the dermatological appearance, in the dermatologically, what you are going to see? You are going to see there will be the rose spots will be there. The rose spot. So remember, if this is again becomes your keyword. The rose spot, this is seen in which condition? Salmonella typhi or the enteric fever. Okay. Enteric fever, you can also call the another name is what? Typhoid fever. Typhoid fever. Now you understand why we call this typhoid fever, because this is caused by the typhoidal pneumonia, typhoidal salmonella, whether it's the salmonella typhi or the salmonella paratyphi ABC. C is not present in India. The diagnosis, remember, for diagnosis, you are going to do the, what you are going to do? You are going to send the one, remember one mnemonic here, that is the BASU. That is the BASU. So B for, remember, you are going to send the blood culture report. The blood culture reports. The blood culture will be positive. If it is the case of the salmonella typhi, it is the positive from first week. Positive from the first week itself. After that, you can go in the first week. Basically, this is the blood culture will be done in the first week. because the first win they have the high specificity and high sensitivity. Specificity means they're the more specific that if it is positive, we can specify more that this is the case of the typhoid fever. So that's why this is the positive from the first week. It means it will be present in the second week also, third week also, and the fourth week also. Then A4 we going for the agglutination test. There would be the agglutination test would be there. In agglutination test, we would be having another test that is, we would be having another name that is known as the Vidal test. And I hope every one of you know that we do one test for the typhoid fever and we call that test is Vidal test. But now you will think that Vidal test is a very good test. And before clinical practice, I was also thinking the same. But Vidal test is not sensitive, not specific. If it is positive also, then again we have to send the blood culture report to the of the patients. Because Vidal test, it can't be positive in if it is a non-typhoid fever also. So that's why the Vidal test, it is a non-specific, neither it is a sensitive nor specific. So what you are going to see in the Vidal test, if it is a 1:20, basically you are going to check about the H antigen or the O antigen. So if it is a 1:20, just if in the question they have mentioned 1:20, so what you have to do, you have to repeat the test after 1 week. Repeat test after 1 week. If it is a 1:80, if it is a 1:80, it means this is the patient is the typhoid carrier. This is the case of the typhoidal carrier. And if it is 1 ratio more than like 100, more than 1:100, then it is a means diagnose. This is the diagnosis of the typhoid. Like for example, if I say that the ratio is 1/400, so it means this patient would be having the IgM, IgG antibody would be positive, and the Vidal test would be positive, and everything. That means that patient would be having typhoid fever. Then, as for we go for the serum test, and the U4 we will be done for the urine test. So basically, this is done in the first week. Vidal test, this is done in the second week. Then serum test we do for the third week, and the urine test we go for the in the fourth week. The urine test we can also go for the first week also. Okay, the serum test and the urine test you have to remember. So this is you have to remember the diagnosis. The diagnosis is what? That is the BASU. The diagnosis you have to remember what is that? That is the BASU. ठीक है? Okay. Okay, so what we have discussed the salmonella. It is a motile bacteria and they have the capsules. So capsules they are made of the polysaccharide. They have the 3 antigens, H antigens, O antigens, or we can go the VI antigens. The VI antigens is the capsular antigens. They produce the black colonies in all the medium. This is the very important keyword you have to remember. And what they will cause? They will cause the enteric fever. Okay. Then enteric fevers most commonly caused by the salmonella typhi. And they also cause the food poisoning, but this is food poisoning caused by the non-typhoidal salmonella. Then it's transmitted through the contaminated food and the water with the human mucus. There will the fecal-oral route would be there. Then clinic abdominal pain, fever with the rigors, headache. They affect the small intestines, Spear's patches, and the rose spots would be seen. The diagnosis, the blood cultures, agglutination test, serum test, urine test would be there. Okay. After that, we would be having, if you want to know the treatment also, the treatment, remember, the treatment you can go for the ciprofloxacin basically. Ciprofloxacin or you can go for the ceftriaxone. Ceftriaxone basically you are going in the regions where the drug resistant strain of the typhoid would be there. Like there is some specific region would be there where you will see the typhoid will be resistant to the ciprofloxacin or the azithromycin. So basically, the ciprofloxacin is the first line drugs. But if it the if any region there will be some strain of the typhoid that is resistant to the ciprofloxacin, then we go for the ceftriaxones. Okay, that you have to remember the ciprofloxacin and the ceftriaxone would be used as the first line treatment for this typhoid fever. The next one is what we would be having. The second one, that is the shigella. That is the shigella. When we say the shigella, it belongs to the which family? It belongs to the Enterobacteriaceae family. Like they belongs the same like the E. coli. The Enterobacteriaceae family. They are catalase positive. They are the catalase positive and they are the nitrate reductase positive. They are catalase positive as well as nitrate reductase positive. While they are the oxidase negative. Okay, they are the oxidase negative. After that, we will discuss about the Helicobacter pylori. In this, we will study there is the triple positive. So that is the catalase positive, oxidase positive, and the urease positive. But shigella, remember, the shigella is the oxidase negative. Now in the shigella, you can see that the no MO is there. So no MO means that is the known motile. These are the known motile or non-capsulated. They are the known motile or the non-capsulated bacteria. And the culture medium also remember for this. The culture medium that you have to remember one culture medium that is the Mac Conky agar. Because this is the common culture medium. So that's why sometimes they can ask you this. So this is the culture medium that is the Mac Conky agar. This is for you that is used in case of the shigella. Now shigella will be having the different species would be there. What is that? Like shigella dysentery. Shigella dysentery would be there. And the shigella flexneri would be there. Shigella flexneri. Shigella boydii would be there. And the shigella soni would be there. Dysentery, remember, this is the most severe. We are discussing about that there is a dysentery would be there. So the dysentery means there will be some kind of the like a bloody diarrhea, you can say. The shigella dysentery. So there will be the patient would be called, this is the most severe. The most severe would be there. Okay. If we talk about the shigella flexneri, the shigella flexneri, remember, this is the most common species that is in India. For Indian students, just remember this, other you don't have to remember. Okay, this is the most common species in India. I don't know which one is Ukraine, and they are not going to ask you this also, and you don't have to remember that also. Okay, so but flexneri you can remember for the Indian students. This is the most common species in India, and the shigella soni, remember, this is the most common species worldwide. The most commonly, that is the shigella soni worldwide, and the flexneri is the most commonly in the India. If we talk about the shigella dysentery, basically we are going to talk because that is the most dangerous one or the most severe one. So what they will shigella dysentery will do, they will cause the shigellosis. Shigella dysentery, they will cause what? They will cause the shigellosis. What is another name of the shigellosis? We can say that is the bacillary dysentery, which is caused by the some bacteria. So that is the bacillary dysentery. If we want to know about the incubation period, so remember they will be having the 12 hours to 5 days. That will be the incubation period. Means for till the 5 days they can survive. And the mode of infection, again, this is like the fecal contaminated food or water. Mode of infection. So what is the mode of infection here? The mode of infection is the contaminated food and water. Contaminated food and water. Again, what symptoms you are going to see in this patient? The symptoms. See, the patient would be having the fever. The patient would be having the fever, of course. The abdominal pain would be there. The abdominal pain would be there. And there will be the diarrhea. And this diarrhea, firstly it will be the watery diarrhea. Then after that, it will progress to another one, that is the bloody diarrhea. So watery diarrhea, then it will progress to bloody diarrhea. Okay, what does that mean? The diarrhea, the dysentery. Dysentery means the bloody diarrhea basically. Okay, that you have to remember. The fever, abdominal pain, and the diarrhea, the watery, and then we will progress to the bloody diarrhea. Can you tell me one question here? There is one bacteria that cause the around 15 to 20 liter water loss, and that will cause the diarrhea basically. And that diarrhea will be having the 15 to 20 liter water loss. Which bacteria is that? Bolo, bolo in Ukraine. So there will be the fever, abdominal pain, and the diarrhea. The diarrhea, like water will progress. The good thing about the cholera is that it will be having no smell, no odor would be there. So that would be the like the good thing here. Otherwise, you can imagine that the 15 liter water loss or 20 liter water diarrhea would be there, water diarrhea, and having the stink or the smell would be there. So whole hospital have to go out. Okay, so that will be the best thing here in this cholera. Then, if remember that one important complication, the complication of the shigella, and this is your question also, that shigella cause one very important disorders, that is the hemolytic uremic syndrome. That is the hemolytic uremic syndrome. When we say why we are calling that shigella dysentery is the severe one, because shigella dysentery, they would be having one toxin would be there, that is known as the Shiga toxin, and this Shiga toxin will be disseminated into due to dissemination of Shiga toxin into glomerular capillaries, into glomerular capillaries. And when this Shiga toxin will be disseminated into the glomerular capillaries, there will be the necrosis of they will cause the necrosis of these glomerular capillaries. Can I write here the GC? It means you can write the full form here, the glomerular capillaries. The necrosis of the glomerular capillaries would be there. Remember that whenever you think about the case of the hemolytic uremic syndrome, so remember three things you have to remember, or you can see the HUS triad, hemolytic uremic syndrome triad would be there. The first thing here, you will see the patient would be having the necrosis of the glomerular capillaries, and when there is a necrosis of the glomerular capillaries would be there will be the acute renal failure would be there. There would be the acute renal failure would be there. What you are going to see here, that the increase of what blood urea nitrogen, there would be the oliguria would be there, and there will be the increase of creatinine. Normally this is 0.7 to 5, around 0.75 creatinine. So if it is very high, it means this is the acute renal failure. We have to go for the dialysis of the patient. Then another symptom that you are going to see here, that is the microangiopathic hemolytic or hemorrhagic anemia. Microangiopathic hemolytic or hemorrhagic anemia. Okay, on the peripheral smear, what you are going to see here, the cystocytes would be present. And another thing you are going to see here, that is the thrombocytopenia, means platelet will be down. If the platelet will be on the downsides, there will be the anemia, like the hemoglobin, the RBC, everything is going on the lower sides, and the cystocytes is present on the peripheral smear. Along with that, you are going to see the creatinine level is high, blood urea nitrogen is high, and the urine output is very, very low. So in this patient, you can think about what hemolytic uremic syndrome. How you will make the diagnosis of Shigella? Diagnosis. For the diagnosis, what you are going to see? We are seeing there is a dysentery. So the dysentery means we have to take the stool sample, and we will take the fresh stool here. We will take the fresh stool, or we will take the stool from the rectum. But fresh stool is the best sample that would be having, and that will help us to make the diagnosis. The treatment, remember the treatment, you are going to see the first line treatment for this condition. The first line treatment, you are going to start with the ciprofloxacin. We are going to start with the ciprofloxacin. After that, you can start with the second line treatment, like we will be having the azithromycin, and other antibiotics that we can start. The here you can remember just one drug, that is the ciprofloxacin. That will be the first line drugs that will see given in the patient with the shigella dysentery. Okay, so shigella dysentery, basically we have the abdominal pain. So there will be the affect the large intestine. They will affect the large intestine. In the large intestine, basically they will affect the sigmoid colon. So remember that if you are talking about the shigella dysentery, this is the belongs to enterobacteria that catalase positive, nitrate reductase positive, and they will be having the shigella dysentery, that is the most severe. So we will be having the shigella flaxneri. This is the most common species in India. Shigella boydii and the shigella soni. Then and the shigella dysentery, of course, this is the most severe condition. This will cause the shigellosis or the bacillary dysentery. This is transmitted again through the contaminated food and the water. The symptoms you are going to see the fever, abdominal pain, or the diarrhea, the large intestine. Then complication, remember that the hemolytic uremic syndrome. So if I ask you hemolytic uremic syndrome, it is caused by which condition? So that is what? That is the shigella. And this is what you are going to see in the hemolytic uremic syndrome. There is a dissemination of the Seeger toxin. The Seeger toxin, it is a part, is the toxin that is present in the shigella dysentery. So this Seeger toxin will be disseminated. This disseminated into the glomerular capillaries, and due to that we will see the necrosis of the glomerular capillaries. And what you are going to see, there is the triad you have to remember, the acute renal failure, anemia, and the thrombocytopenia would be there. How you will make the diagnosis of the shigella dysentery? You have to take the fresh stool sample, and that is the best sample to make the diagnosis. You can also take the rectum sample, the rectum stool, the stool from the rectum regions. Then the treatment, you remember the first line treatment you are going to see, give the ciprofloxacin. Now if you want to see the questions, it has become very easy now. A patient with a fever, headache, abdominal pain, recurrent vomiting is there, then diarrhea and the tenesmus, incomplete defecation. So stool occurs 12 times daily, scanty, contain lot of mucus, pus or the streaks of the blood. So this is all because of the infection or the the injury of the abdominal large intestine. Then his sigmoid gut is standard and hardened. What is your diagnosis? So diagnosis here will become the dysentery. Here if you talk about the cholera, so remember the cholera, it is caused by the Vibrio cholerae. Okay, in the Vibrio cholerae you are going to see iso-osmolar diarrhea. There will be the iso-osmolar diarrhea would be there. Around there with the 20 liter water loss would be there. But best thing here, that is the no smell and they have the no odor. No odor. Okay. Then after that the child is complained of the night and hungry abdominal pain. Dekho, there is a night and hungry. Hungry means hungry abdominal pain. This is my esophagus. This is my stomach. This is my stomach and this is my duodenum. Okay. Now if I'm eating some food, my food is going here. But if I'm not eating food, it means my food is going into the duodenum. So I will be having the pain due to duodenum. If I say if I'm eating something and I will be having the pain, that means the pain is due to some gastric movement. So this is due to gastric ulcer, and we call here is the duodenal ulcer. Okay. So this question we can be having the both conditions. Okay, this is the case of the Helicobacter pylori, because Helicobacter pylori can cause the gastric ulcer also and can cause the duodenal ulcer also. Basically they cause the peptic ulcer. In the peptic ulcer we would be having the gastric ulcer and also we would be having the duodenal ulcer. So remember, if they will talk about the gastric ulcer, we will discuss it further on when the question will come. The gastric ulcer, when we are eating some food, so it means our food is going into the stomach. So whenever the food is going into the stomach, what will be secreted? HCl, the acid will be secreted in our body, and when the acid would be secreted out, it means there will be some pain would be there. It will irritate the mucosa layer, so that's why there will be the pain. And after 2 hours, this food will be going into the duodenum. So after the 2 hours, after eating after 2 hours of eating any food or taking any thing from the mouth, so it means there will be what will be there? Duodenal ulcer would be there, and there will be the pain. So that we will discuss separately. We will divide that, differentiate them. So at the fibroscopine area of the bulbus of the duodenum, so you can see here the duodenum, the ulcerative defect of 4 mm. So you can see here in the question they already mentioned everything. Fibroscopy, there will be the duodenal ulcer is mentioned. The floor is obstructed with the fibrin and HP is positive. Means what is the HP? Helicobacter pylori is positive. Helicobacter pylori. So administer the optimum schemes of the treatments. So let's first do with the question, then we will go towards the Helicobacter pylori and discuss about everything about the Helicobacter pylori. See, when we say about the Helicobacter pylori, the treatment of the Helicobacter pylori, we will give the triple therapy. We will give the triple therapy. In triple therapy of the Helicobacter pylori, remember, there would be what we will give here in the triple therapy. We will give the omeprazole, we will give the metronidazole, or we will give the clarithromycin. Either we will give the omeprazole, clarithromycin, or amoxicillin. Okay, but sir, here is no metronidazole. Then how you are saying that? Or there is no amoxicillin? We can see two options: the omeprazole and the clarithromycin, but there is no option of the metronidazole or the amoxicillin. So remember, this is the metronidazole. This is what? Metronidazole. Another name of the metronidazole or the brand name of the metronidazole is the tricopolo. The metronidazole is also known as the tricopolo. And another drugs we can give the omeprazole, clarithromycin, or so remember that OCM or the OCA. So these are the triple therapy that will give in the patients with the Helicobacter pylori. In the Crocon, I hope you have studied about that there is a, in case of the Helicobacter pylori, you had studied about the PPI, that is the prazoles. But here we are studying about that the triple therapy would be given. Okay, basically we will start with the PPI, but after that we will go for the endoscopy and then we will diagnose with the Helicobacter pylori. Then we have to start with the triple therapy. So this triple therapy is OCM or the OCA. So let's discuss about what Helicobacter pylori in details. When we say about the Helicobacter pylori, this Helicobacter pylori, first of all, it is the gram-negative bacteria. It is the gram-negative bacteria. Okay, this Helicobacter pylori, these are the urease positive. Means you can say the firstly you can write it as the triple positive bacteria. So you will easily able to revise it. Triple positive bacteria. Triple positive bacteria means they are the three positive. What are these three positive? You have to remember UOC. Okay, so how it will be easy? UCO. So you CUO. Or you can remember OUS. Okay, you can remember OUS. So they are the oxidase positive. They are the oxidase positive. They are the urease positive. They are the urease positive. And they are the notes as C. OUC. OUC means they are the catalase positive. They are the catalase positive. So they are the oxidase positive. They are the urease positive. They are the catalase positive. Why they are surviving in the acidic medium? You know, our guest HCl, they will be having around the pH around 1.4. And gastric acid. So how they will survive in this acidic medium? They will survive with the help of this urease. This urease is what they will produce the basically they will produce the two enzymes. They will produce
Excuse me, sir. Can you repeat the question? What were you asking?
Question?
Yes, sir.
I mean, अच्छा जो मैंने पूछा है. See, I was asking that कि जो हमारे पास क्या पूछा था? Helicobacter pylori, it will going into the stomach. Okay, and they will cause the gastric ulcers. So in the gastric ulcer, they will be having the loads of the acid secretion. Hydrochloride HCl secret होता है ना काफी ज्यादा. So there will the loads of acid secretion would be there. So how they will survive in this acidic medium? How they will survive? So this was the question. Because Helicobacter
Okay,
pylori,
sir.
they will, हाँ जी, बताओ.
Okay, sir. I understand.
हाँ, so they will survive with the help of answer बताना था. Survive. They will survive with the help of this enzyme that is known as the. They produce the two enzymes basically. That is the urease and protease. The urease and the protease enzyme. देखो, this urease what they will do? They create the alkaline medium. They will create the alkaline mediums, and that will help them to survive in the acidic environment. Okay, and this protease will be help in the digesting. The protease will be help in the digesting. So these are the two enzymes that is produced by the Helicobacter pylori. So that's why they are giving the, when you are going to do for the oxidase test, they will give the oxidase positive. When you are going for the urease test, basically we going for the urea breath test for the diagnosis. And in that condition also we will get the urease positive. And if it is urea breath test is positive, it means we have the Helicobacter pylori would be there. Then we would be having the catalase positive would be there. Okay. Then remember that if we talk about the most common site where they will grow or where they will survive. So they will go into the stomach. They will go into the stomach. In the stomach, we would be having the see, this is what? This is the cardiac part. This is the fundus part. This is the body, and this is the antrum. This is the antrum. This is the body. This is the fundus, and this is the cardiac part of the stomach. Cardiac part of the stomach. Okay. This Helicobacter pylori, this is the most common site of this is what? That is the antrum. They will present in the gastric antrum of stomach. They are what? They are the motile. They are the motile. Means they have the flagella. So what they can do? They can migrate. They can migrate proximally. They might migrate to the body part and then migrate to the fundus part, and they can migrate to the cardiac part. So they can migrate proximally. They can migrate the proximally, or also of course they can migrate the distally as well. And again, the mode of infection, it is again the similar, like we have discussed in case of the shigella or the salmonella. The mode of infection, remember, that would be the fecal-oral route. That would be the fecal-oral, or we can say oro-oral route. Okay, so they can spread through the fecal-oral route or the oro-oral route. What they will cause? When we say about the Helicobacter pylori, the 80% is responsible for 80% is responsible for the chronic superficial gastritis. Chronic superficial gastritis. Gastritis means some kind of inflammation would be there. Gastritis means some kind of inflammation. So this is the histological inflammation of the gastric mucosa. That is what? That the gastritis. And the 20%, remember, the 20% or 15 to 20% or less than that basically. The less than 20% would be there that will be responsible for the duodenal ulcer. You can say peptic ulcer, because the duodenal ulcer, they can also cause the gastric ulcer also. They can also responsible for the gastric adenocarcinoma, means cancer, or they are also responsible for the maltoma. They are also responsible for the maltoma. Okay, then ये क्या one second. Okay, so here they are responsible for the 80% responsible for the chronic superficial gastritis, and the 20% they are responsible for the peptic ulcer, gastric adenocarcinoma, and the maltoma. Then if we talk about the what is the basically the gastritis, देखो, when we say about the gastritis it is a histologically inflammation of gastric mucosa. So we will going to see about the histological appearance. So the histological inflammation of what? Gastric mucosa. The mucosa is the innermost covering, so the mucosa would be inflamed. And now see the some trick. See, when we see the gastritis, we are seeing that the 80% is caused by the Helicobacter pylori. But I am saying here, the gastritis, the most common cause of the gastritis is still NSAID. What are the NSAID? Non-steroidal anti-inflammatory drugs. We discussed already about the COX-1 inhibitors. The COX-1 inhibitors like the diclofenac, ibuprofen, and all these drugs, they cause the gastric problems. So they will cause the gastritis. So remember that the gastritis, it is causes is what? That is the NSAIDs, and more than the infections. Then if we talk about the gastritis further on, the gastritis, there are the two types. We call this as the acute condition. The acute, this will be the phlegmonous, means bacterial would be there, the phlegmonous gastritis. And another one is the chronic gastritis. Chronic, basically superficial gastritis. Okay. So if we say acute phlegmonous gastritis, this is the rare one. This is the rarely happen. But this is the severely progressive inflammation of gastric wall. Progressive inflammation of gastric wall. So due to which what you're going to see, there would be the thickening of the wall and the gas formation. There will be the wall thickening. Wall thickening means mucosal wall. The mucosal wall will be thick. There will be the thickening of wall and gas formation would be there. Thickening of the wall and gas formation would be there. And this is seen in which condition? It's seen in immunocompromised people. This is seen in immunocompromised people. Okay, and the causative organisms, the organisms that cause the acute phlegmonous gastritis is not the Helicobacter pylori. Okay, that you have to remember. Its causative organism is that is our streptococci. Streptococci, and second one is E. coli. Streptococci. After that, the E. coli can also cause the acute phlegmonous gastritis. And again, here a patient will be complaining of abdominal pain, fever, and the vomiting. But here you have to see that this is the acute conditions. Means the patient will be coming, not recurrent would be there, not recurrent vomiting. There will be the acute phlegmonous, means patient will be having the first time severely progressive inflammation of the gastric wall. There is a thickening. When we will do the fibroscopy, we are going to see there is a thickening of the wall. And the causative organism, you have to remember, there is the streptococci. The patient will come to you with the abdominal pain, the fever, and the vomiting. Okay, this is the what? Acute phlegmonous gastritis. When we say the chronic superficial gastritis, it means in the chronic gastritis, there will be some lymphocytes would be there. Because remember that when we talk about the total leukocyte count or the WBC. In we will be having the neutrophils. The neutrophils is seen in basically in the bacterial infection, and also remember they are also seen in the acute infection. Whenever there will be the acute infection, the neutrophils will come first. The lymphocytes, they will be coming later on, like in the chronic conditions, or the macrophage will be there in the chronic conditions. So the lymphocytes, and along with that you are going to see the plasma cells would be there. When we say the chronic superficial gastritis, so there are the three conditions. We would be having the type A, type B, and the type C. The type A is what? That is the autoimmune condition. Type A is what? That is the autoimmune condition. Type A is what? Autoimmune. And the type B is what? They will be responsible for the peptic ulcers or the adenocarcinoma. That is our Helicobacter pylori. Type B was Helicobacter pylori. And type C, they will cause the some kind of the maltoma. And so all these will be there. The maltoma and adenocarcinoma, all, like long list is there. Okay, that is the basically non-atropic. You can see here that is the non-atropic pangastritis. Pan means like everything. All the layers would be affected, or the complete gastritis would be involved. Complete gastric involvement would be there. That is the non-atropic. Non-atropic means there is the no reduction of the size. Atrophy means reduction in the size and the shape of the gastric mucosa. So that we are going to see in the autoimmune type A condition and the type B condition. Okay. So the main thing that you have to remember here, that Helicobacter pylori, they will cause what? The chronic superficial gastritis. Along with that, they will cause the peptic ulcer, they will cause the microadenoma, and they can also cause the maltoma as well. Okay, is that okay? Everybody? Give me a thumbs up if everything is okay. यस सुडाक्रम दीपेंद्र समझ आ रहा है so after that we are going to start with the management. See, the management is important for your chronic preparation also, and also you have to remember for the lifetime. Okay, don't forget this, because the management is the things that you have to remember for that, very important for the Helicobacter pylori. What is the management that I already told you? Okay, before that I think diagnosis. You not make how you will make the diagnosis. Okay, before that please write the diagnosis. How you will make the diagnosis. So for the diagnosis, remember that for the diagnosis you are going to do the non-invasive techniques and the invasive techniques. The invasive techniques you can go for the adenocarcinoma, but before any invasive techniques, we will start with the non-invasive. Non-invasive means we are not putting anything inside. Okay, so that is the like first we will go the urea breath test. Urea breath test, UBT. There will the urea breath test would be there. In the urea breath test, what you are going to see? What you are going to see in the urea breath test? You will see that the patient would be having the urease positive. Means the urease would be there, and if the urease would be there, so if the urease would be there, it means that the urea blood test is positive, and we your device is connected to the connection. Wait a second. That is the stool antigen test. That is the stool antigen test. You can also go for the serology as well, and for the invasive you can go for the biopsy, or you can also go for the endoscopy. If an endoscopy, if you are going to ulcer present, if If ulcer present, then we will go for the H pylori testing, and in the H pylori testings, if it will be the positive, then we will go for the treatment. So the endoscopy, this biopsy, urea blood test. Basically, first we will start with the urea blood test. With urea blood test, we will going to see about the UDH, and if the UDH is positive, it means we will be having the B. Then we can go for the further, like based on the symptoms and everything. But for you have to remember for the exam point of view. So just remember everything that is given in on your screen. Then you have to start with the treatment. The treatment, remember the management. The management you have to start with the drug therapy. The drug therapy is what? That is the triple therapy you are going to see. The triple therapy. So there you will gain the 14-day regime, the 14-day regime of OCA, OCA or OCM. What is the OCA or OCM? OCA means we would be having the omeprazole. Omeprazole. Basically, we would be having the PPI, proton pump inhibitors, and the antibiotics. This is given like around 20 mg BD. If it is the pantoprazole can also be given. The pantoprazole dose is what? 40 mg BD. Then we can be having the C. C means we can have to know clarithromycin. Clarithromycin. So clarithromycin is given 500 mg BD. Then A, we would be having the amoxicillin. If you don't want to remember the dose, then don't remember. I think I would recommend you to revise the dose also, because they are I will write only the few dose only. So like for example, this triple therapy, because this triple therapy is important for the clinical practice also. Okay, amoxicillin, this is around 1 gram BD you have to give it. Okay, BD means you understand what the BD means? 2 times a day. Then M4, remember M4 we can be having the metronidazole. And metronidazole you have to give the 500 mg BD. 500 mg BD you have to give. Okay, then you can go to the second line treatment, where you can add the tetracycline, bismuth, and also if the like in the some area there is some resistance would be there, so that you have to divide again. Like if you have to any resistant, like the person is resistant to the PPI, person resistant to the amoxicillin, so you have to give another antibiotic in that patient. Okay, but that is not for your concern. Just remember, we would be having the some triple therapy would be there: omeprazole, clarithromycin, amoxicillin. If it is not, that is not in the option, omeprazole, clarithromycin, metronidazole. That's it. Okay, A and M. That you have to remember. ठीक है, is that clear? बोलो clear. It's clear right till now. So do quickly revise this. But the first delivery, see, a woman delivered a child. It was her 5th pregnancy, but the first delivery. It means the 4th child was aborted. Mother blood group is A, Rh negative. Newborn is Rh positive. So mother blood group is Rh negative, and the newborn is Rh positive. So there is a high chances of what? Rh incompatibility. The level of indirect bilirubin in umbilical blood was 58. So the hemoglobin is 140. RBC is down in 2 hours. The level of indirect bilirubin turned 82. Means bilirubin has been increased. The patient is shifting to the erythroblastosis fetalis. They already mentioned everything. The hemolytic disease of the newborn, icteric anemic type, Rh incompatibility. We have seen that this is the Rh negative mother and Rh positive child. So there would be the Rh incompatibility would be there. So what you have to do that in this condition, the blood replacement, or means you have to do the blood transfusion. So the conservative therapy. Replacement of what? Blood transfusion. What about these options? This is also right. Okay. So now this type of the questions are not coming. Now they are understanding the English. So now this mistake will not occur in the exam. Okay. So they are the mistake that they was doing before, but now they are doing such type, not doing such type of the mistake. So don't worry about that. Don't bother about that. Okay, after that we have the question number 23. A mother with an infant visited the pediatricians for the expert advice. Her baby was born with a body weight 3.2 kg and the body length 50 centimeter. He is a 1 year old now. How many teeth the baby should have? Why should I tell the baby? Go to the dentist. है ना? और चलो बता देते हैं. Okay, before that, let's discuss something about the little bit about the pediatrics. See, when we say about the pediatrics, you have to understand the three conditions. The first, we would be having the prenatal condition. First, you have to remember that this is one condition that is known as the prenatal condition. After that, we would be having the natal condition and the postnatal condition. So, they are the three conditions: prenatal, natal, and the postnatal. So, in prenatal condition, we would be having the till birth. The prenatal means till the birth. So this will be, there will be the ovum period. There will be the ovum. When there will be the ovum formation would be there. The ovum formation that is occurring 0 to 2 weeks. The time interval, remember for the ovum, that is 0 to 2 weeks. Between the between the 3 to 8 weeks, what we call this is known as the embryo. This is known as the embryo in womb. Then from 9 weeks to birth, 9 weeks to birth, what we call this as the fetus. What we call this as the fetus. So what is the ovum? The ovum we call till 2 weeks. After that, the ovum will be changed to the embryo from 3 to 8 weeks. Now from 8 weeks onwards, we will call this as the fetus till the birth. In the natal conditions, remember, we would be having the three conditions. We would be called the neonate. When we call the child as the neonate just after the birth. Just after the birth means 0 to 28 days for 1 month basically. Then in this condition we would be having the two early neonate. This is the early neonate, or we call it as the late neonate. The early neonate, when we call the baby as early neonate from the 0 to 7 days. From 0 to 7 days. And the late neonate, remember, we call this as the 7 to 28 days. 7 to 28 days would be there. Then there will be the postnatal period. The postnatal we would be having the toddler. We will call the toddler. Then we call this baby as the preschool children. The preschool child. Or we call this child as the school children. So the toddler, when we call the toddler, from 1 to 3 years. So 1 to 3 years will be there. Then preschool, there would be the 3 to 6 years. That is known as the preschool children. And the school children, remember, that is the 6 to 12 years. The 6 to 12 years is known as the school children. Okay, sir, between the 28 days and till 1 year, what we call this? So from day 28 to from the day 28 to 1 year, what we call this children, this child is known as the infant. This child is known as the infant. So the infant is less than 1 year and more than 28 days. What the child, when we call the child infant, the infant will be called when the child will be less than 1 year and more than 28 days. We call the child as, or the baby as, the infant baby. Okay. Then remember that what is the normal weight of the fetus? What is the normal weight of fetus? What is the normal weight of fetus? बच्चे का नॉर्मल वजन कितना होता है? That is 2.5 to 4 kg. 2.5 to 4 kg. So the 2.5 4 kg average would be around, average weight of the baby is, average So that will be the average weight of the baby. Then if we call there is a three conditions will raise here. What are these three conditions? We having the lower birth weight baby, the lower birth weight. The lower birth weight means when the baby would be less than 2.5 kg. When the baby would be less than 2.5 kg. When we call the very low birth weight baby, very low birth. That is means when the baby would be less than 1.5 kg. There would be the extremely low birth weight baby means when the baby weight would be less than 1 kg. अब इतना बता दिया तो मोर देन अगर 4 kg हो गया तो व्हाट वी कॉल दिस इफ इट इज मोर देन 4 kg व्हाट वी कॉल दिस चिल्ड्रन so more than 4 kg remember we call this as the macrosomic baby means baby having the high weight more weight so that is a macrosomic baby big baby बड़ा बड़ा बच्चा पैदा हो बड़ा बड़ा so that is a macrosomic baby big इतनी देर बाद याद आई ये क्या हुआ ये क्या हुआ हाँ भाई नेटवर्क चला गया फोन का नेटवर्क बंद ऑन है ना इस वजह से चल रहा है For less, the expected weight for the less than 1 year old child x plus 9 by 2. For 1 to 6 year 2x plus 8, 7x minus 5 by 2. So now you have to revise that continuously. X plus 9 by 2, 2x plus 8, 2x plus 8, 7x minus 5 by 2. Again, x plus 9 by 2, 2x plus 8, 7x minus 5 by 2. You have to remember that it is if it's less than 1 year, that is the x plus 9 by 2, 1 to 6 year, 2x plus 8, and 7 to 12 year old child, 7x minus 5 by 2, that you have to remember. And remember that we have to remember some normal value also. If you want to remember expected weight, the expected weight of 1 year old child, so that would be around 10 kg. That would be around 10 kg would be there. Okay, and remember that the weight of baby doubles by 5 months. Doubles by 5 months. For example, if the baby born with a 2.5 kg, so after 5 months, what will be the weight of the baby? What will be the weight of the baby? Double, like 5 kg would be there, and triples by 1 year. Triples by 1 year. Okay. If you want to, so what will be the triple by 1 year? It means it will be around 2.5 multiply 3. So it will be 7.5 kg at the 1 year. And remember, this is the expected, like the average. When we are taking the 1 year old child, so we are taking the average weight of the baby. So expected weight of the 1 year old child, this is the average, that is the 10 kg. But if you want to calculate, remember that if the baby at the birth is 2.5 or the 3 kg, like the baby at the birth, we will take the average value. We will take the average value. The baby birth is 3 kg, so it will be around, in the 5 months, it will be around 6 kg. Then in the 1 year, it will be 9 kg. Okay, so that will be how we will calculate the, like you have to remember the expected weight based on these two sentences. Then remember the length, the normal length at birth. What is the normal length at birth? That will be 50 centimeter. Again, this is the average we will take. At the 1 year, the length of the baby, 1 year, the length of the baby would be 75 centimeter. And at the 4 year, the length of the baby would be 100 centimeters. So now can you see that at the birth the length is 50 centimeter, at the 4 year the length is 100 centimeter. So you can easily understand here that is the height doubles by which year? Doubles by 4 years. And at the 12 years, you can see the height of the baby would be around 150 centimeter. So now you can see 50 multiply 3. So height will be height triples by 12 years. So after 12 years, the height will be tripled. And after 4 years, the height will be double of the birth height. How you will calculate the height? So remember the formula of the height formula you have to remember. The height formula, remember, there will be the age multiply 6 plus 77. Whatever the age of the children, then plus 6 you have to add, multiply 6 you have to do, and plus in that you have to add the 77. Okay, so this is about our length. Then remember that if you talk about the head circumference, the normal head circumference, that would be around 35 centimeter. That would be around 35 centimeter. From 0 to 3 months, it would be increased 2 centimeter per month. 2 centimeter per month. Then from 3 to 6 months, the head circumference increased by 1 centimeter per month. From 6 to 12 months, head circumference increased by 0.5 centimeter per month. Okay. There is a, if you are able to see more than 35 centimeter, if the more than 35 centimeter, then this is the case of the macrocephalic, means head would be on the big size. So that we call the, if head circumference is more than 35 centimeter, we call this is the macrocephalic child. Okay. What instrument you use for the length measurement? Let me write here. For length measurement, remember there is a one instrument that is known as the infantometer. That is the infantometer. And for the height measurement, there is another device that is known as the stadiometer. Okay. So for length measurement, we would be having the infantometers, and for the height measurements, we would be having the stadiometers would be there. Okay, you don't need to revise anything. I am just telling you. See, prenatal, you understand. Dekho. As the name is suggesting, is what? That is the, dekho. As the name is suggesting, what is the name is suggesting? We having the three condition is there. The one we would be having the natal. The natal means like just after the delivery. So just after the delivery, it means the baby is what? Having the neonate condition. The neonate means that the newly born baby. Neonate means newly born baby. But till what time you can call this newly born baby? It will be like around 1 month. It will be called as newly, new baby is there. So you can understand there is the 1 month. So that is the neonate. That is we call the neo. Neo means new. So neonate 0 to 28 days. After that, we will divide that into the early neonate. The early neonate or the late neonate. Early neonate we would be having 0 to 7 days, and the late neonate we would be having 7 to 28 days. So before that, we would be having the prenatal. The prenatal, when the baby was in the womb. So there in the womb, we would be having the first, there will be the ovum formation. And ovum formation, it's occurring in the first 2 weeks, 0 to 2 weeks. Then after that, there is the formation of the embryo. The embryo formation occurring at the 3 to 8 weeks. Then we would be having the fetus. And the fetus we call around 9 to birth. 9 weeks till the birth. We called it the fetus. So there are the three conditions in the prenatal: ovum, then we would be having the embryo, and we call the fetus. The postnatal, remember, we would be having again the toddler. We call the toddler from till 3 years. Then we would be having the preschool children from 3 to 6 years, and the school going children, that is called the 6 to 12 years. Okay. 1 second. Also remember there will be the one thing here that is physiologically weight loss. Physiological weight loss. You already had seen the little babies. So you have maybe you have noticed that the newborn baby loses the 10% of the body weight. The newborn baby loses 10% of its body weight. That is known as the physiological weight loss. That is known as the physiological weight loss. Okay. Then our question was about the dental formula. There was how many teeth the baby should have. So remember that if we talk about the dental formula, what is the dental formula in adults? How many teeth present in adults?
32.
32. Okay. So that will be the 2, 1, 2, 3, 2, 1, 2, 3. 2, 1, 2, 3, 2, 1, 2, 3. Divided, multiply by 2. What does it mean? Can you tell me the name of all the teeth, all the tooth? How many type of the teeth we have?
And we have 4.
What types?
Incisor, canine, premolar, and molar.
Okay, that is the incisors. We have the canine, we have the premolar, and we have the molar. So these are the 4 type of the teeth we have. So remember that if you talk about the 2, 1, 2, 3, that is the incisor, canine, premolar, and the molar. It means on the upper side. So how we will take it? See again. This is what? This is my half side. This is my above. This is my below. Take above that. Above we have the above teeth and the below teeth. So I will take this as that. This is 2, 1, 2, 3. This is 2, 1, 2, 3. Multiply 2. This is multiply 2. So 2, 1, 2, 3. 2, 1, 2, 3. Multiply 2. So it will become the 20. It will become the 32. So in incisor, there is the 2 incisor on this side, 2 incisor on this side, 2 incisor on the below side, 2 incisor on here side. 1 canine here, 1 canine here, 1 canine here, 1 canine. So there are the 4 canine total. Again, we would be having the 4 premolar on the upper side, the 4 premolar on the lower side, 3 molar on the upper side, 3 molar on the lower side, 3 molar on the lower side, and the 3 molar on the upper and 3 molar on the lower. That will be on the 6 on the one side, 6 on another side. So they will become around 32. But when we talk about the children, so remember that when we in the children, this formula is not there. In the children, they will be having the lesser teeth. In children, they would be having 2102 divided by 2102 multiply 2. So it will be. You understand what? How we will calculate this formula? Speak from your vocal cords. Hello. Did you understand? Do speak from your vocal cords. Yes or no? Please, please, please.
Yes, sir.
Ika, did you understand that? So there is a 2, 1, 2, 3 means, and the same like we would be having in the children's 2, 1, 0, 2, 2, 1, 0, 2. So around 20, I think it will becomes around 20. So there the 20 teeth will be seen in the children's. Then you have to remember that these are 2 types of the teeth. The first things that you will see in the children, the first teeth is known as the milk teeth or the temporary milk teeth or the temporary teeth. Or the temporary teeth. Another one is what that is known as the permanent teeth. These are the milk teeth are the 2102, 2102, and leave it. So they are the, like, you have to remember whatever these four things. The first primary teeth. What is the first primary teeth? The first primary teeth is the lower central incision. The first primary teeth is the lower central incision. It comes around 6 to 7 months. It's come around 6 to 7 months. Okay, then we would be having the last primary teeth. Last primary teeth means basically we would the temporary teeth. The last primary teeth, remember, that is the M2. That is the M2, and it comes at 18 months. It comes at 18 months. It comes at 18 months. Then we will say about the first permanent teeth. The first permanent teeth. The first permanent teeth is the first molar. The first molar, and it comes around 6 to 7 years. It comes around 6 to 7 years. Then we have the last permanent teeth. Last permanent teeth, and every one of you know that is our third molar, wisdom teeth. And it's 18 years. After 18 years, basically, this is known as the wisdom teeth. Okay, just remember this. The milk teeth temporary, and if you don't want to remember this, forget this. No any pressure, because now currently there is a very less chances, 1% chances that they will ask about the dentist things in any exam basically. And but you should know about what is the, like, how many teeth we would be having the dental, because this is the anatomical part, and you should know what is the incisor, canines, premolar, molar, and this is for your general knowledge also. That you should know, because you are the medical student, so you should know about how many teeth we have, what kind of the teeth we would be having, and what are the types of the teeth. Is it a temporary or the permanent teeth would be there? So that you have to remember. So if you see that he is 1 year old child, how many teeth the baby should have? For that we have the formula. So the number of teeth will be calculated with the help of the number of teeth. The number of teeth would be equals to x minus 4. The x is what? Age in months. Age in months. So according to our question number, you can see here that is the baby is 1 year old child. This is the 1 year old child. So 1 year we would be having number of teeth is equals to, okay, let me write it 1 year. The child is 1 year. The 1 year old, so it will be around 12 months. It will be around 12 months. So how number of the teeth would be? Numbers is equals to 12 minus 4. So it will be comes out 8. It will be comes out 8. So that's why how many teeth the baby should have? That should be having at 1 year old. He should be having the he or she whatever he or she should be having the 8 teeth should be there. Okay, is that clear? A mother consulted a pediatrician about her son. His son was born with a body mass of 3 kg and length of 48 centimeter. He is 1 year old now. So what is the required normal mass? So we have already discussed that at around 1 year old child we would be having the 10 kg weight would be there. And also you can calculate with the formula. So you can see the 1 year old child. So what was the formula for 1 year old child? So here. So you can see here the 2x plus 8. Here if you want to do 2x plus 8, so it will be around 2 multiply 1 plus 8. So it will be 10. And if you want to calculate here the x in months, so it will be 12 plus 9 by 2. That will be around 12 plus 9 by 2. It will 21.2. So it will be 10.5. Okay. So if it is exactly 1 month, exactly 1 year, then it will be the 10.5. But if it is more than 1 year, then it will be the formula that we will use here, that is the this one, 1 to 6 year. Okay, so that's why here you will be the answer. You have to remember the x plus 9 by 2 formula. A 6-month-old infant was born with a body mass 3 kg and length 50 centimeter. He is given natural feeding. How many times per day the infant should be fed? Tell me this. Firstly, this is the 6-month-old infant is there. and the bone with the body mass 3 kg and the length is length is normal, everything is normal. He is given the natural feeding. He is given the natural feeding. How many times per day the infant should be fed? So it will be, you have to remember that 6-month-old child would be fed around 5 feeds. 5 feeds per day. 5 feeds per day. And here the 6 month, and out of 5 feeds, remember the 5 feeds, the 3 would be the natural feed. 3 would be the natural feed. This is for the 6 month old child, 6 or above. 3 natural feed, and the 2 would be there, that is the supplement. Like you can take the outer food. And the less than 6 months, exclusively breastfeeding. Exclusively breastfeeding would be there. Natural feeding, exclusively breastfeeding would be there. 6.5 months is given natural feeding since birth. Body mass 3.5, length is also okay. How many times per day the supplement should be given? So how many times? You will add the 2 supplements here. The 2 supplement food. Okay, up feeding means. A 2-month-old healthy, 2-month-old healthy infant with a good appetite is given artificial bedding since he turned 1 month old. When it is recommended, they was giving the artificial feeding since he turned 1 month old. But what you will recommend as a doctor to start the corrective feeding or the fruit juice, you will recommend after 6 months. Okay, so that's why you will mention here the 6 months. So this is your answer. Just remember this question. I will share you the one image. You will able to solve. Other nothing has to be there. Or you can just remember this question itself. If you don't, I will share you the image. Let me share you. Okay, you can see this image, that is the borders of heart related dullness. And this is not so important, so that's why I'm not going to discuss it. So just remember this question. This type of question will not come in the exam. Okay, the rest is all about the respiratory. So the respiratory, that we're going to discuss it tomorrow. Okay, tell me this question. A 14-year-old boy has a rheumatism. On the last 2 years, he has 3 rheumatic attacks. What course of rheumatism does the patient have? Already he is having continuous attack or the recurrent. So you have the prolonged. We have discussed everything, all the profile axis or the course of the rheumatism. So do revise that and you will be able to understand. See, whenever you will be in the doubt of anything, when you are not able